talk, right, about the
base camp.
Base. Mm-hmm. The ambulatory thing, the Gil Weintraub in dermatology tried to launch a series of noontime conferences, sort of same thing, virtual modules and things like that the Chiefs were going to lead last year, and completely didn't work. And I was like, well, some of these seem like they would be outpatient type things. Maybe you should collaborate on doing this in that setting. And I told him in my feedback, because he was kind of disappointed, obviously, that his thing didn't work. But I was like, they might be looking for a couple more modules, and you've already created the modules, and it's for common derm conditions. I'm like,
that seems to fit pretty well. I hope to be connected. We definitely had hurdles in putting that together. So
yeah,
we can talk about how we overcame some of those.
It's the same platform because he collaborated also with Dr. Feinstat on it.
Oh,
so it's the exact same platform. Feels like it could shift right over with no big problem.
Yeah, that is fantastic. Thank you for thinking of me.
Yeah. Well, that's the advantage for me of going to everything, is that I get to think oh, that person should talk to that person. That's how that's going to go. Great. Lots of collaborations.
Hi, Amy. Good to see you.
Hello. How are you doing?
Doing okay. How about you?
Good. How's your third black belt coming along?
We have him, you mean the 18-month-old who on command will do squats. We'll say, just squat. He'll just get down. So yes, the third black belt is coming along. I'd say par for
good.
For here. Yeah, we'll see soon enough.
I feel like it's probably destiny.
I think so too. Thanks for asking.
That's awesome.
All right. Well, in this 1 minute lead up, I'm going to say congratulations to everyone who's doing oral presentation today. I think our committee had a hard time choosing people for oral because there were a lot of good ones. And so you all rose to the top, and we really appreciate your hard work during such difficult time. So just congratulations. I know the posters have felt like oral presentations too, but we kind of keep them at a little faster clip, and there hasn't been as much time for questions. So I'm looking forward to today's group of discussions. I also want to make a plug for the keynote talk tomorrow at noon, either in person or in virtual in Zoom, with Dr. Zoe Cohen, who's an immunology teacher at Arizona, who's coming to give that talk, and then also to honor her father with that legacy. So without further ado, I'm going to get us started with our first presenter. Robin Gisbert is joining us, and the title of her abstract is Preliminary Findings of a 90-Day Virtual Heartfulness Meditation Program to Improve Resilience Among Healthcare Students. All right.
Well, welcome everybody. Right out of the gate, huh? Great. It's really nice to be here and be here with all of you. And as Shanta said, we're going to be talking about just some preliminary findings of a 90-day study that's looking at virtual heartfulness meditation to improve resilience among students of our healthcare campus. Now, I have to just pause and say thank you so much to Dr. Margaret Shankman and Meredith Mueller, who have been my collaborators and mentors, and many other important roles along the way with this. So I want to give them credit and respect in that way. Brief introduction: I'm a physical therapist, assistant professor with the physical therapy program, where I've been since 2006. I am a proud, not survivor anymore, I am a thriver of multiple rounds of professional and personal burnout. I have additional training in compassion fatigue and as a heart math provider. My disclosure is loud and clear. I'm a fallible and biased human, and I'm working on those things each and every day, and I'm a cat lover. Now, this background I'm going to share with you will not surprise anyone in this room. Our students on our campus are what I call kindled for professional burnout. And again, this won't surprise any of you, but I want to share some information, some data with you. Health professionals have been found to have concerning levels of depression and anxiety, in fact, 6 times higher than the general population. This was pre-COVID, all of 5 of these studies. Depression and anxiety has been demonstrated to predispose students to professional level burnout. And since we've been in this pandemic, depending on what you read, between 49 and 50%, 55% of all healthcare workers are reporting burnout during this pandemic. So that includes, nurses, dentists, therapists, physician assistants, but also social workers, CNAs, janitorial staff, housekeeping staff. This study did. It's a big problem. Resilience, or the ability to adapt in the face of stress, is a skill that can improve and has been shown to be protective against burnout. And heartfulness meditation, the intervention in our study, has been shown to improve burnout among healthcare workers. The purpose of our study, Heartfulness, which we call HEART for short, is to investigate the feasibility and delivery of a 90-day heartfulness meditation practice. It's delivered virtually. We started this when COVID hit. Any effects we're looking for in terms of resilience, depression, and anxiety that we know is a problem. This is a randomized and controlled mixed methods intervention study. We have the intervention group that's meditating and a group of controls that are waitlisted to cross over. And so far, each one of our controls has been lined up to cross over into meditation. At the time of writing this for you all, 26 students were enrolled. You can see the split there. And 6 of the meditators completed so far the 90-day meditation. And I'll be reporting the findings on those students. Students were surveyed at the beginning, baseline, in the middle, 45 days, and at the end. And our meditators were also interviewed at these 3 time points. What we've been measuring and tracking are the number of meditation sessions completed each week. We're measuring anxiety and depression with the hospital anxiety and depression scale, and that ability to adapt, or resiliency, with what's called the CD-RISC, or the Connor-Davidson resiliency scale. And at the end, we'll have some questions about acceptability and how things went for them. The interview for the qualitative questions is a very open-ended motivational interviewing type prompt, where I sit with the students and I ask them what they might hope to gain from participating in meditation in general. And then we evoke and explore a little more if there's anything that they might want to see change in their life around health or relationships, in their academics or work, because these students may be more in didactic or in clinical, or a little bit of both while they're in the study. At the midpoint and the end, then I sit with them again and I ask, describe any changes or benefits, if any, that they've noticed in these same categories, and I'm tracking all that information. The intervention that the students receive is a 90-day training program in heartfulness meditation, which is a style of meditation in which we focus on our hearts. These students receive one-on-one meditation with a trainer each week. They have a personal trainer they stay with for the whole study, and those sessions are arranged at their convenience and last 30 minutes. They're invited into group meditation with trainers, all of this virtual, and we ramp up from once a week to up to 4 times a week by the end of the study. Students are also trained in how to begin and invest in themselves in a personal meditation program. I want to share with you first these quantitative results from the HADS. And I listed all the numbers here because some of you may be familiar with the score and some of you may not. What's important to me is that the cutoff score for mental health of depression and anxiety is an 8. So higher scores become concerning over an 8 in depression or anxiety. And so far, what I'm seeing in this sample of 6 is very representative of people who have started and not yet completed the study as well. These baseline anxiety scores are all above the cutoff for our students. Following the intervention, you can see how individual scores dropped and that our aggregate scores have moved from well above the cutoff to below the cutoff. in terms of resiliency, on the CD-RISC, higher scores represent more robust resiliency or ability to adapt to stress. And we know that our students have stress. And we're seeing improvements there. But what does this resiliency score really mean? I wanted to put this in context, and this is just straight from the Connor-Davidson tool itself. Our students, when they start the study, the aggregate score, their resiliency is somewhere around patients with generalized anxiety and psychiatric outpatients. And after the meditation, with that improvement that we saw, their resiliency is landing somewhere between primary care patients, yet still lower than the general population. These same individuals that we task and ask to take care of the general population with resiliency lower than that of the general population. What's striking me the most are these qualitative results. The words that the students are sharing with me, and I want to share some with you. One student at the end of the study said, "I'm more patient and I'm less irritable overall." Another, "I'm sleeping better." It goes without saying what better sleep can do for our students' mental health, physical health. "I have improved concentration," another tool we need in academics and in life. One student said, "I'm able to recognize when my heart starts to race and ground myself in the moment with patience." Another student, "I am noticing deeper self-awareness and less imposter syndrome." Yes, please, less of that. And lastly, one comment that struck me so much, a student who took the board exam. "My mind was calm. I was in the zone. This was so different from my typical experience with exams." Fully aware this is such a small sample size and more information will be needed. But I think some of these findings are generalizable. Student mental health is a concern on our campus. It's been a priority on our campus. And Heartfulness meditation is making a positive impact in this small group so far. So the discussion question I really pose is, could this intervention or something similar be embedded inside of curriculum to develop resilient practitioners of the future? I've got some references for you. I'll stop sharing and I welcome feedback, questions, concerns from this group.
Thank Dr. Gisbert, to you and to your colleagues for that presentation. I had a quick question about the general population that's used as a reference point. What's their age there? Is that like our students' age or?
I think it's broader.
Okay, but it does include the like 20 to 30-year-olds.
Mm-hmm. Okay. Yeah. I love that question, Shanta, because we know some of this burnout and anxiety is hitting our younger practitioners harder than the older practitioners. It's a thoughtful consideration.
Well, and I think some of those skills around resiliency come in some situations with experience or age. Dr. Bernard, do you have your hand raised for a question?
Yeah, you can keep, I don't want to interrupt. I just wanted to make sure I could ask one. So my question was, of the 6 students that were in that, was that a mixture of students across the campus, like med students, PT, PA, or was it like all med students? I'm just curious. Mm-hmm. And if you found a difference between the types of students on the campus.
Mm-hmm. Yeah, I appreciate that question. You know, those are physical therapy students, and now I've rolled in another couple handfuls of students from the med program between years 1 and 4. We're going to recruit students from every program, and so far on the surface there actually looks to be a little difference from program to program, but that's one of the things that we're going to have to pull out as we get all this information in. We really did, in all transparency, you know, start with what was convenient to get the study started.
Sure.
Yeah. Mm-hmm.
Sure, and I know faculty are interested in participating as well. There were several talks and posters throughout this week about burnout and resiliency and well-being. And I think probably most people here have seen the announcement about Dr. Lottie Derby, who will be joining us from the Mayo Clinic. I know this will be an area of interest and support. I agree with Dr. Bernard, really impressive to see those, especially those anxiety scores in such a small sample change so rapidly.
Mm-hmm.
We do track longitudinally the Derby scale in our students here in the med school. So one thing that we might be able to do if we piloted an intervention is to actually look back at the data prior to the intervention already on that well-being scale. That's like the Maslach, it's like the Maslach burnout scale, but it's patented by Dr. Derby instead. All right. Other questions or comments? All right, thanks. We look forward to an update on more, and I'm also
coming.
happy to help with enrollment on the School of Medicine side of things, which, as you know, includes PT and PA and MD students as well. I would also be particularly interested in these interventions in our population that's historically underrepresented in medicine. A lot of the literature around well-being and resilience and wellness and burnout doesn't look at that population specifically, especially as it relates to interventions, although there's some emerging data that suggests that minority populations have higher rates, potentially even at baseline. And you can think of lots of hypotheses around microaggressions or societal things that may contribute to that.
We'll be able to pull a little of that out as we do have some demographics up front in the study. And so for people who are wanting to self-identify in the demographic portion, we may be able to pull some story out of that to some degree.
I think it'd be helpful to, to enrich our population of recruitment too, which the ODI the Office of Diversity can help with enriching the population that participates.
Thank you.
Sometimes it's hard to get them to sign up. So yeah, thanks again. All right, I'm going to transition to our next speaker, Emmeline Kim. The title of her abstract and co-authors is Current Gaps in Medical Education as Illustrated by the COVID-19 Pandemic, Interviews with Physicians Across Various Medical Specialties. Student Dr. Kim, take it away.
Okay, awesome. So hello, everyone. I'm Emmeline. I'm a third-year medical student, and I'm super excited to share my research today, which is on the current gaps in medical education as illustrated by the COVID-19 pandemic. I have no financial disclosures or conflicts of interest. So I'm sure everyone listening is very well aware of the background, but to take us back to when this all started in March of 2020, the WHO officially declared COVID-19 a pandemic. Trump declared a state of national emergency. We saw PPE shortages, and then a lot of our non-emergent procedures were put on hold amongst many, many other changes. And so at the time, we didn't know a lot of the things that we know now. And so that kind of was the start or in the inspiration for this project. And our aim was to try to understand the effect of the pandemic on physicians in different medical specialties across Colorado. And we started this project in April of 2020. So we interviewed 31 physicians in 19 different specialties in the state of Colorado. And during our interviews, we asked a standard set of interview questions that focused on the impact of the pandemic. So we asked how this is impacting their practices, their specialties, the effect on patient care, how they're adapting their practice because of the pandemic, and then the impact on trainees' education. Then we took all of the interviews, we transcribed them, and we analyzed the transcript to look for some common themes that were mentioned. We tallied up those themes, and then we identified the themes that highlighted gaps in current medical education and some opportunities for positive change in medical education. Then this past January, we sent up a follow-up survey, and we included some of those gaps that we identified and some possible solutions to them. So here are the specialties and the number of physicians interviewed in each. So the most highly represented are critical care physicians and pediatricians here. And then these are the results from the initial interview transcripts. So this is the number of times that these themes were mentioned across all of the transcripts. So the most commonly or frequently mentioned is the lack of data to drive clinical decisions. That was mentioned 20 times. Then after that, people mentioned the disproportionate impact on underserved communities at 18 times, then also a presentation of unique and positive training opportunities, some challenges in communication with patients and their families, as well as patient anxiety. And these are some of the representative quotes from the transcripts. So I won't read all of them, but there's some mention of, again, lack of data and not having a lot of treatments to offer at the time, health disparities becoming more obvious, and then how this is an opportunity to change the healthcare system. Okay, so in January of 2022, we sent a follow-up survey. We gave them the themes. We had some proposed solutions to those themes. And then on a 5-point Likert scale, we asked them if they strongly agree with the theme and proposed solution and whether they regard this issue as very important. So the one that people most strongly agreed with was the theme of the lack of data to drive decisions, and then the proposed solution being challenging students to navigate cases that may lack the absolute answers. So that was at 57.1%. And then an issue that respondents regarded as the most important at 89.7% was a disproportionate impact on underserved communities, and the solution being providing more education on healthcare policy and healthcare economics. But really, for all the themes and all the proposed solutions, no respondents disagreed with the theme and the proposed solution, and no one said that they don't believe these issues are important to address in medical education. So for mental health impact, we said, we can provide more integrated training on mental health disorders. And then for challenges in communication with patients and their families, we said we can incorporate more training and practice with virtual health visits. So in that same follow-up survey, we also presented some of the less common themes that were mentioned and asked, which of these do you think should also be addressed in medical education now that it's 2022? And respondents were allowed to choose more than one of these themes. So the most common one being at 50%, the prioritization of patients when volume is at full capacity. And then at 42.9%, people said the potential impacts of delayed healthcare due to the pandemic should also be addressed in medical education, as well as the financial impact on hospitals, providers, and private practices. And then at 28.6%, they said minimizing risk through PPE protocol changes and restricting contact should be addressed as well. So what did we learn from this study? We identified the common themes during our interviews back in 2020 that presented great opportunities for positive change in our education. And some of these include encouraging students to grapple with the lack of data to drive clinical decisions, increase training in telehealth, learning more on healthcare policy and reform, and then integrating mental health training across all specialties. And then in our follow-up survey in 2022, physicians reflected that it's very important for medical students to understand how to triage and then emphasize training in preventive care. So since the start of the pandemic, we now know how COVID-19 has affected a lot of different aspects, some of the most common being mental health, physician burnout, use of telehealth visits, and then the disproportionate impact on underserved populations. And all of that, as I'm sure many of you have seen in the media or published in literature. So we know all of that, but our study focuses on additional areas impacted and how we can address them. So as much as COVID-19 has, had some very tragic effects, it really also illuminated a lot of opportunities for students to be better prepared and to be physicians of the future that we are not adequately doing right now. So students should be taught to be nimble and adaptable in the face of uncertainty, to address healthcare disparities, and then to stay up to date with new methods of healthcare delivery. So for right now, that would be telemedicine. And then the changes that we make right now to medical education will have positive impacts well beyond the pandemic. So we recognize limitations in this study being the small sample size of the initial interviewees, and then the small sample size for the follow-up survey. This was all done at the University of Colorado, and everyone interviewed was Colorado associated faculty. And then we only had the 2 time points in April of 2020 and January of 2022. So our future directions would include doing some follow-up interviews with the people who had responded to the surveys in 2022 to talk about some more details on recommending change for medical education. I'd like to acknowledge Stephanie, Carly, and Amanda also for their contributions to this project, and then Dr. Bernard and Dr. Lee for their mentorship, and everyone who participated in our interviews and in our follow-up survey, because this project would not have been possible without them. And I will stop sharing my screen, but I am happy to answer any questions.
Very nicely done. Thank you, Evelyn. Really nice presentation and important work. Dr. Rodriguez has her hand up with the first question.
I'm sorry to always dominate, Chantel.
It's perfect. I love the participation. Are you kidding?
So, Emmeline, thank you so much for doing this, being a part of this study. And I'm from the physical therapy program. And so I'm curious, when the pandemic hit us, it really it hit our curriculum hard. We had to actually move one of our clinical experiences because clinics were not accepting students at that time. And do you know if that also occurred in the medical curriculum as well?
Yeah, so at the start, so this was in April 2020. And so especially with the PPE shortages, a lot of the transcripts did mention, it's more so in residency that they're not allowed to come in for some of the procedural things, surgical training. There was some concern about how residents would be able to catch up with that aspect in terms of the volume.
Right, thank you. And then I had one more question. You identified some great opportunities or gaps in medical school education. And do you think those suggestions were to incorporate those ideas into more of the didactic portion of medical school curriculum, or incorporate it in the time that med students are in the clinic?
I think that's a super good question. I think where it's possible to kind of do it longitudinally across all 4 years for us. So both in the classroom and the clinics, I think that would be really awesome. One of the things that I can think of is, learning about how and why underserved communities or minority communities are disproportionately impacted, and then going into clinic and maybe doing like a volunteer clinic or a low income clinic, and getting to kind of see that pan out clinically. So I think both would be ideal.
Okay, thank you so much.
On that theme of health disparities, it was interesting to me to see in your data that early on that primarily people were feeling like, I don't know what to do. We don't have enough information about how to treat these patients. But then later it became this burden on the underserved populations is what's so overwhelming. And I wonder if, because we had some treatments, specifically also preventive treatment of the vaccine, that some of that frustration shifted to this recognition that we've lost this opportunity to care for people, and those disparities are widening, and calling attention to that. Did you hear any frustration? That was, I guess, just a comment. Did you hear any frustration about the vaccine? Because I just reflecting on my own time, feeling so overwhelmed in April of 2020, and then being so frustrated about still being in this situation in January of 2022, especially given the access to the vaccine that we felt like not everyone was taking advantage of.
Yeah, so in the follow-up survey, it was mostly the multiple choice questions and then really focused on gaps to address in medical education. So there was no explicit mention about the vaccine or the fact that this is all still going on, but there was a lot of emphasis on needing to learn the importance of preventive care for everyone in all specialties and really learning how to triage. And that's true for across all specialties, not just emergency med or primary care. So those are the things that came up.
I wondered if that question around triaging was really a marker for frustration that we couldn't get people into the hospital for things that they needed because we're filled with patients who were unable to get the vaccine or for whatever reason, potentially also related to disparities.
Yeah.
I don't know if anybody else has a comment, just unmute and shoot out. The other thing I was interested in is the difference between what was important to people versus what we felt like we had a solution for. And sort of that, like you really called out the fact that while people were really upset and frustrated about the disparities, there weren't as many like educational solutions for those. And I think your comments about hands-on activities of volunteering, recognizing disparities, changing the curriculum around bias, not just learning about policy, but actually making change, something that needs to be done at a more systems level approach. And I think a lot of physicians sometimes feel is outside of their control, but we've gotten a bigger call as health professionals to really address these issues instead of saying, oh, not my problem.
Yeah.
Cool.
I would comment really quickly that I was on the project with Emmeline, looking over the follow-up surveys. There was at least one or two people who wrote, isn't this being handled in the new curriculum? So with the new Trek curriculum, with the health and society modules, I think some of this is starting to be addressed. So, and they were anonymous, so we don't know who said that, but it must be someone who knows quite well what's coming up in the new curriculum. So I thought, just you should know that.
Oh, good. Yeah, I was going to say we have tried to do a lot more around health disparities and addressing this, and also giving students a voice to be able to speak up and also to have advocacy. So it's really good to see that is recommended. Dr. Bernard, you also know that our COVID electives address these topics too. And I love the tie to curiosity and have used it a lot when I'm talking to new applicants about why do we need to learn science continuously? Well, because if you didn't, you would probably have missed that whole thing that was called the SARS-CoV-2 because we didn't teach it to you in the first year of medical school. And I didn't learn it in med school either. Thanks again for a great presentation, Emmeline, and congratulations to you and your collaborators as well. I'm going to shift to our next presentation from Eric Sawyer. The title of his abstract is A Collaborative Approach to Bringing IPE into a Real-World Clinical Environment. Thank you for being here today and for sharing your work with us.
Yeah, thank you for having us. And I actually have the pleasure of having two of my collaborators who are going to also present with me. So I have Dr. Doug Wilson, who will start us off, and Dr. Stephanie Hansen, who will kind of bring it home. So Doug, I'll let you go ahead and kick us off.
Great. Thanks, Dr. Sawyer.
All righty, thank you. So we're giving the tag team approach a try today. If you could go to the next slide, please. Interprofessional education is a wonderful concept. And we do a lot in the classroom and activities and simulations. But in talking with students and other faculty, sometimes the real world IPE activities can be hard to come by. Next slide. Well, a majority of dentists, up to 62%, and 80% of dental students in one study complained of musculoskeletal pain. In the dental school, we have students the first semester of their first year complaining of a pain in the neck, and it's not always because of the faculty. These musculoskeletal disorders can curtail a dental career in its prime earning years. After several years about talking about ergonomics, telling students to sit up straight, we really didn't see any benefit or changing behavior. So we decided that we in the School of Dental Medicine don't really have the the knowledge base to solve the problem. So in thinking about it, we brainstormed and said, hey, why don't we talk to physical therapy and see if they can help us? Initially, I envisioned getting a few physical therapy students to come over, spend some time demonstrating how to prevent injuries. And as we discussed it with the faculty in physical therapy, we quickly came to the realization that this could be a big win for both schools. The School of Dental Medicine gets some fantastic instruction in ergonomics and injury prevention. And next slide. And the physical therapy department gets a chance to do a workplace evaluation as well as some hands-on teaching injury prevention, both of which are their core skills. And next slide. So Eric and Stephanie will tell you what we did and what we found, but I'd like to end my section by telling you that there's some great IPE opportunities out there that are ripe for the taking. And I've never seen students so excited about IPE as when they're actually in the clinic doing it hands-on. So with that, we'll transition to Eric.
All right, thank you so much. So I'm going to be talking about our participants and our methods that we used in this particular pilot project. So we had 3 student cohorts that were involved in the project. The first were second-year physical therapy students that were concurrently enrolled in their 3rd musculoskeletal conditions course, as well as their 2nd movement science course. And as Dr. Wilson talked about, in those courses that we really dial into the physical therapist role in occupational medicine, and that includes specifically how to complete a job site analysis, as well as ergonomics concepts. And so we felt like this was a great marriage to be able to put that into context and be able to take them, as I'm going to tell you here in a moment, into the dental clinic to actually work with dental students. So the other 2 cohorts we had were 3rd and 4th year dental students who are working up to as many as 25 hours a week in the clinic, performing dental restoration and cleaning procedures. And then we also involved 2nd year students. Now, these students are not doing as much of the clinic work yet at this point, but they, as he said, have already received some ergonomic and injury prevention education in their curriculum. So what our plan was at the time was to educate our students on these occupational medicine or ergonomic concepts and have them go observe the 3rd and 4th year dental students actually working with real patients and perform a job site analysis, gather back to kind of talk about what they saw, put together some educational handouts on proper postures, ergonomics, and injury prevention exercises, and then return to the dental clinic to teach that same group of students some things that would help them prevent some of those musculoskeletal problems in their career. And unfortunately, the stars didn't line up this semester with the scheduling between the 2 programs. And that's why we ended up having them observe the 3rd and 4th year students, but then they went back and delivered the educational session to the 2nd year students. So we started by having our 2nd year students view some modules on the topics that we just talked about. And then we had them review a couple of papers in the literature about prevalence of musculoskeletal disorders in dental professionals, both dental students and dental workers. And then we had them engage in that planning session. So what that involved was having them talk about what kind of questions do you want to ask them, maybe about whether or not they have pain and where do they have pain, and what are some of the harder tasks that they have to do when they're performing these procedures on patients, to get an idea of the things that bother them and some of the harder things. And then also to plan out things that they might want to measure, whether that was the range of motion that they need to be able to reach over a patient with their arm and hold it in that position, whether it was how much grip or pinch strength that they might have to be able to hold on to a tool. And we really dialed them into looking for risk factors for musculoskeletal injuries, like repetitive motions, prolonged or awkward postures, tool vibration exposure, prolonged reaching, all those sorts of things. And as you can imagine, dental professionals do those things all the time. So we had them engage in the planning session and then come over and do an hour and a half of observation. And they were free to walk around the dental clinic and watch different students working and doing different procedures. They were available to ask questions, and the 3rd and 4th year students were great about, pausing or in between patients, answering questions and doing measurements and that sort of thing. we developed a couple of surveys. So the first was surveys for the PT students, which we really tried to hone in on their confidence and their knowledge for being able to complete a job site analysis and provide this educational session. So we had them rate their knowledge pre-IPE experience, 0 to 5. 0 would be no confidence or no knowledge on that skill, and then 5 being very confident or very knowledgeable. So we had them do a pre and then a post survey after the IPE sessions. And then we also had the dental students complete a survey on the value of the IPE experience for them. And we asked them some questions about whether or not they currently had musculoskeletal complaints, where those were, their pain severity, and that sort of thing. As you can see here on the slide, we've got a picture of the educational session with some of our PT students teaching some stretches to the dental students. All right, so before I hand it off to Stephanie, I'll just talk briefly about our response rates. So we were very pleased to have good response rates from the PT students. Not as great of response rates in the 3rd and 4th year dental students, and Stephanie will talk a little bit about that. Only about 30% of those students who are being observed while they were working. And then 2/3 or 67% responded to the survey amongst the 2nd year students. So with that, I'll hand it off to Stephanie to talk about what we learned from our data and our conclusions.
So as Eric mentioned, we surveyed about what sort of musculoskeletal pains they were experiencing, the dental students were already experiencing. And they had a slightly higher response rate than the literature suggests for dental students, 87 and 89% accordingly. And they had a various range of areas of their body that they experienced pain. Low back, neck, upper back, and were the most prevalent. And then shoulders, hands and wrists and such coming in a little bit lower. Next slide. From the dental students, the experience, they rated this as a really highly rated interprofessional experience as good or very good. And you can see among the 2nd year students versus the 3rd and 4th year students, kind of a little bit different value to the importance to their education value, and importance to their career. We believe that part of the difference here is related to the 3rd and 4th years not getting the ergonomic education following the observation of the job analysis experience. And as Eric alluded to, the stars didn't really align for us to use the same cohort of dental students that we observed and then provided education to. So next slide. The PT students, however, felt that this was very valuable to them. They even rated it higher than all course material related to occupational medicine and learning about job analyses and providing ergonomic education. So they had a high confidence following the job analysis and how to perform that, and as well as confidence in providing ergonomics and work injury education prevention. Next slide. And looking at kind of, what we take from all this, as we mentioned, the 2nd year students rated it a little bit higher than the 3rd and 4th year dental students for the reasons I described, and Doug agreed that this was, kind of one of the issues there. But we have we intend to circle back with the 3rd and 4th year students this spring and allow them to get the same education that the 2nd year students received, so that hopefully if they were to take another survey, they would see the value in that. The interprofessional education session had a really high positive impact for PT students in their confidence in learning the skills. Higher than I anticipated as someone that lives in occupational medicine, education and experience professionally as well. It was quite surprising to me, and I was, it just shows the value of having real world experience in this. The dental students also had, as I mentioned, they had a little bit higher prevalence of musculoskeletal injury than the literature suggests. So, the literature suggests that about 80% of dental students have musculoskeletal complaints, and this population was about 87 to 89%. The distribution of the body areas involved as well was pretty variable. The literature suggests about 15% of the population may have pain in the neck area, 15% in low back area, and about 13% in the thoracic region and the wrists. So this population had a much higher distribution in those specific body areas as well. Next slide. So following this experience, we found some things, the pilot experience, we found some things that we would like to change for the future, but overall, it was a really rewarding experience for the faculty, the students of School of Dental Medicine, and the PT students. And we would like to have a future session with the 3rd and 4th year students so that they can also receive this wonderful education and take it into their careers so that they may value it more for their professional experience after school. As I continue to say, the PT students were able to apply the course concepts in a real world experience right on our campus. And that was immensely helpful for them because occupational medicine can be kind of a difficult subsection of physical therapy to really understand unless you get experience. And we just want to take this experience in the future, optimize it. It was a novel experience, and we learned a lot of things from it, but overall it was really rewarding. Next slide. And we want to thank all the attendees and then my collaborators on this project.
Thank you so much. I think one of the things the Academy really liked about this was the interdisciplinary piece. And if anybody's on the IPE Council, I think we're always thinking about ways to make our experiences for students in the interprofessional campus more authentic. I would even be thinking about, let's see if we could get the council to agree to let us pilot a bunch of authentic things that come from the schools themselves. Parenthetically, I just always say that I admire the posture of my PT colleagues all the time on the regular here on the campus, and we'll be looking out for our dental colleagues as well. I thought it would be interesting to see if you could measure whether or not the 2nd year students who became 3rd and 4th year students had a decrease in their pain based on this intervention to really show an outcome based on that. And I'm trying to sit up a little straighter myself. Really fun. Thank you. If it's okay, I'm going to put a bug in Suzanne Brandenburg's ear to kind of look at this and think about whether or not this would be a model for IPE. I think all of our students on the campus would like to show, here's a skill that I have that can help you, my colleague, in this interprofessional space.
So I actually have several ideas with working for we're working with nursing and pharmacy. So I think the field is ripe for opportunity there.
Great. Thanks, Dr. Wilson. All right, thanks to all 3 of you. Our next presenter is Yasmin Sakro. Dr. Sakro's abstract is entitled Resident Self-Assessment and Faculty Assessment Using the Internal Medicine Milestones, Evaluating Trends by Postgraduate Year and Gender.
Thank you very much for that introduction, Dr. Zimmer. And thank you for that prior presentation. I love the mutually beneficial aspect of that. I love that collaborative learning. And so in that vein, I wanted to talk more about resident self-assessment and faculty assessment, and really look at the internal medicine milestones and how these trends might change by graduate year and by gender. I'm thrilled to present this work on behalf of my collaborators, Krithika Suresh, Drs. Erin Murphy, Janet Corral, and Karen Chaco. So to give you a little bit of background, I think as most of us know, self-assessment is essential to lifelong professional development. But really, when you look in the internal medicine residencies, you really haven't seen many studies to date. There has been prior studies with our surgical colleagues, and really what they found in the surgical residencies is that when they tried to match resident assessment and faculty assessment, this was moderately accurate. I'll give some numbers for that a little bit later in comparison to ours. And they also saw that in women resident surgeons, there was risk of underestimating their abilities in comparison to their male surgeon counterparts. So we more closely wanted to look at this in our internal medicine residents and saw this as a very opportunistic way to do this in terms of our evaluations at our semi-annual exams with our residents. I'm going to go back even a little bit further to talk about the background of our milestones. In 2001, the ACG made core competencies are these 6 key areas, which many in this virtual room I'm sure know about: patient care, medical knowledge, systems-based practices, problem-based learning, professionalism, and interpersonal skills. And then in 2013, the milestones came along. And really, this was based on the Dreyfus model of acquisition of skills. This provides a framework for residency programs to move residents forward using a shared language. And so milestones really describe the trajectory within the core competencies. And here you can see that we have an intern begin as a beginner. And our hope is that by the time that they graduate, they are proficient, that they are ready for unsupervised practice. That is our goal to get them through their 3 years with us in internal medicine. And so the name milestones makes sense. This seems akin to a baby's developmental milestones to walking. And to expand the metaphor even more, in residency, we can put up safety gates and we can provide cushions and a safe place to fall. However, eventually one day that baby is going to find the basement stairs. We have to prepare them to guide through that safely. Diving into these domains, so here are the 6 core competencies we mentioned before. Under that become 22 different areas. This looks like a lot, I know, but within each subject, there's about 2 to 5 that a resident can consider as a strength or an area to improve. So using these new milestones, we said, we want to identify the themes for which a milestone might be a strength or an area of improvement, depending on where a resident is in their residency training. We also wanted to measure the degree of agreement. How well do residents match what a faculty assessor thinks about their status or their progress in their training? And then last, we wanted to see, are there any trends based on gender in these resident milestone assessments? Overall, this was a study from spring of 2016 to winter of 2018. It involved 346 internal medicine residents and 16 faculty evaluators. These are all assistant program directors and a program director within IM. And again, I'm showing all these 22 so you can see this is the list the residents choose from. And so a resident chooses 2 independently on their own, 2 strengths, 2 areas to improve, noted the resident by the smartphone in hand. And then the faculty chooses 2 strengths and 2 areas of improvement. I've noted the faculty by that ancient artifact of the briefcase in hand. And then they meet twice a year and they decide together, what do we do with the self-assessment? How do we move forward? How are your evaluations looking? What career advising can we do based on these assessments and moving forward? How we measured agreement is using the CAPA statistic. This is used to give a quantitative measure of the magnitude of agreement between 2 observers. We use the faculty evaluator assessment as the gold standard to compare against. And in the study, agreement is defined as the resident faculty pair choosing at least one of those same milestones or one domain in a certain occasion. We also corrected for chance agreements between 2 independent raters. And so what are our results? I'm going to first start by looking at how residents and faculty chose what is the strength by year of training, what was the most picked upon. And so in our PGY 1 year, they felt their strengths were most often patient care and history. In the second year, it was patient care, but the management plan of the patient. And then in the third year, it was patient care, but independent management. You can almost see the resident baby going from crawling to cruising to walking. A really nice showing of that developmental milestone. Now, if we're looking at the areas of improvement in the first year, they agreed upon that independent management continues to be an area to work on. In the second year, again, that faculty resident pair has agreed independent management was the top one seen in the PGY 2-year. I'm going to harken back to my prior slide to show that in the last one, the third years had decided, finally, strength is my independent management. So it's not a surprise that this time it changes to systems-based practices. They can now focus on systems, institution, quality effect, different things beyond just the independent care of the patient. I'm now going to talk about agreement between the residents and the faculty members. And when we look at strengths overall across the program, we see that the individual milestone, this is a fair agreement. I've shown the degrees of that kappa statistic to the right. If they're just to choose by domain, by one of their 6 core competencies, it becomes even better, it's moderate. Similarly, that's seen in our areas of improvement, that they're fairly good by identifying the individual milestone. They are better at just figuring out what that core competency is that they can match with their faculty member. Last is this area of level of agreement by resident gender. A trend we noticed is in the domain for areas of improvement. Female residents in their first year had fair agreement with the faculty at 0.256, but this kappa value increased at each progressive year of training so that in the PGY 3-year, it is then 4.462. Whereas with male residents, the opposite trend is noted. Agreement is moderate in the first year, then lessens progressively in the PGY 2 and PGY 3-year to fair agreement. What to make all of this? Overall, I took away that patient care is a foundational strength that both residents and faculty members had the most concordance on. Worrying whether this is a strength or an area of improvement, patient care came down to the foundation of that. Once independent patient care is no longer a top concern, then resident focus can broaden to the larger picture of systems-based practices. This makes sense again, I think, developmentally. Internal medicine residents were fair to moderate in agreement to faculty assessments using the milestones. And that gender trends of resident faculty concordance for domains of improvement may be taken into consideration when providing feedback to residents. So I put this picture here to emphasize, maybe it's not so much the interreliability of agreement based on gender, but the collaborative learning process between resident and faculty as a result of that self-assessment. That's what's essential in development. Think about it, if we have inaccurate, negative self-perceptions identified, it's timely, informative feedback that may then help the residents develop a more accurate expectance of their future performance. And maybe this differs between females and males, how this feedback is taken in and how it is worked on. Some limitations, this was a 2.5-year study period. I wonder if faculty experience in their assessment, if people are new to the APD position, whether they've been there in 10 to 15 years, if they are better at that assessment. And again, this was single site here at CU. And so for future, one thing to consider is there something seen with a faculty gender with matched pair? Of our APDs, 2/3 are female. Did that play into this in some way? I wonder. And then also we have new milestones. As of 2020, new ones have been released. And these include things like digital health, knowledge of systemic and individual factors of well-being, and then lo and behold, reflective practice and our commitment to personal growth. So seeing how these further play in, though it can't be quite compared to the surveys we did before. I think overall, this just further emphasizes the importance of resident self-assessment in their professional development overall. And so with that, I'd like to thank my collaborators listed here, particularly to our residents and our faculty who've been involved in this and make this all happen. Thank you.
Thanks, Dr. Sakura. This makes me want to be a program director again. I assume that the direction, the direction of correlation between the female residents and their faculty members was that the females underrated.
So we didn't have nominal values to compare. It was just whether they could pick the milestones to match. In prior studies, it had been, I assessed myself as a 7, a faculty member did a 9, and they could compare a difference. So it wasn't quite the same in that sort of analysis. We didn't do by the numbers. But seeing that they could match better their faculty as time went, I think was an interesting trend to see.
What do you make of the males not matching later?
It's hard quite what to say, and I don't want to make generalizations for all of this. But I really do think, again, it's about that collaboration that happens once you get that feedback. What do you do with it? And there are some theories of expectation that I was reading about, something from DeVoe in 1980. But basically, do females have an expectation of that they're going to have a low performance? So when you have a low performance, and someone says it's a low performance, you think that might be your skill. Whereas if someone else were to see it, not think that it's just luck or fortune that happens. So if you see that low performance as your skill, then maybe you work on it more. And then in this model, it's further said that maybe males see as if they have a low performance, they expect a high performance, and maybe it's just bad luck. And so they don't see it as a lack of skill or ability to maybe work on necessarily. So can't say that explains it, but just trying to look at self-perceptions and gender differences, that's some of the theories I came across.
One thumbnail way that I assessed that with our residents was to get in 2020 was to give them the milestones upon entry and ask them to place where they were on every single one of them, and then go over that with the advisor. And we saw a big difference between the way, brand new PGY1s rated themselves based on gender, with all of the female residents overall rating themselves lower than their male counterparts, although everybody just graduated from medical school. We never did the back study to look and see, was there anything about how many got honors and clerkships or their grades or any of those kinds of things that might have been related. Interesting.
Thank you very much. Thanks.
I just had a comment. I really appreciated your presentation, and I loved your use of the developmental milestones. Thank you to from the PTs for doing that. But I really just loved how you put it together and the conclusions you came to. So thank you.
Thank you very much. I appreciate that too.
Great. All right. Well, looking forward to lots of collaborations and follow-up studies from this one. And I'm sure that the Aptum group nationally would be interested in hearing these results too. All right, great. Thanks, Dr. Sacro. Thanks to everyone for your participation today. And again, shout out to Jody for organizing all of us and keeping us on time and having all of the posters and everything uploaded. If you missed any sessions, go to the website and take a look. There's a lot of richness out there. Thanks, everybody.